the hemodynamic and the anatomical data should make sense in the light of a diagnosis. Okay, so if we are talking about severe aortic stenosis, we have to have an aortic valve which is morphologically thickened, degenerative, and calcified with restricted opening, and we have to elicit a gradient of more than 40 mean. So this is the reconciliation of the hemodynamic and anatomical data together to make a diagnosis. So sometimes there is discrepancy. And here comes the job of the echocardiologist. When you have discrepancy, you know how to sort out this discrepancy, how to settle the disputes, how to make reconciliation. يعني مثلا إذا عندك a morphologically stenotic valve, aortic valve, لكن the mean gradient is lower than 40. So what are you going to do here? Let's hear from you. What are you going to do? Any idea? So you are gonna look further. Yeah, hello وسهلا.
I will look for the LV function first.
Yes, very good.
And I will see the cavity of the LV also.
Okay.
Because I want to see if the low gradient is due to LV dysfunction or due to low flow if you have a small cavity of the LV.
Exactly.
Or
exactly.
I can see if I am in the proper angle for the
very good.
the CW.
Exactly. Exactly. طيب يا معاوية, on the flip side, if you have an aortic valve that looks pliable and soft and opening widely, but I get a gradient of more than 40 mean, this is also discrepancy, isn't it?
Yes, yes.
What do you think about this?
Because sometimes the visual aspect might mislead you. You might see the valve is opening well, but maybe it is not that.
Okay.
Sometimes obstruction, we have seen cases at the tips of the aortic valve.
Yes, exactly.
I will see if the patient is anemic. The other
exactly. Yeah. Okay. Good. Good. If the patient something that can something that can produce high gradient in non-stenotic aortic valve like severe aortic regurgitation, hyperdynamic circulation, anemia, subaortic stenosis, stuff like that. لكن أنا بس أختلف مع وعاوية في نقطة واحدة, إنه المورphology is so unlikely to deceive you. يعني the morphological data should always be your frame of reference. So the data that you are gonna fall back upon is the morphological data. And you have to look at the hemodynamic data in this light. Does it make sense in the light of the morphological data or not? So you judge the hemodynamic data is standing on the anatomical data and not vice versa. And this is so important in echo. Okay, this is so important in echo to the extent that you can be so ready to dismiss any significant hemodynamic data if the anatomy is not consistent. يعني مثلا if you elicit grade 3 diastolic dysfunction, the patient had normal ejection fraction, had no LVH, the left atrium is normal in size and volume, there is a problem. I can't take it as diastolic dysfunction grade 3-4. Because the anatomy is not consistent with this advanced grade of diastolic dysfunction. So the anatomy is paramount. The anatomy is the frame of reference. Okay? Good. What we are going to learn here in this quick session is the Doppler shift equation, how we calculate the volume, continuity equation, Benoulli equation, CW, PW, max and mean pressure gradient, And if we have time, we're gonna talk about pulmonary artery systolic pressure. طبعا كل الأشياء دي are more or less familiar by now. We are just going to consolidate it in a way or another. The Doppler shift equation. Are you familiar with this equation? Yes, no?
No.
Really? طيب, if no, then this is a good chance to discuss it لأنها it is at the center of the ecophysics. So, these equations, the Doppler shift equation, volume equation, continuity, and Bernoulli equation are the 4 major equations you should know by heart. Okay? مش فقط لأنك you are going to be an echocardiologist. No, for any practicing cardiologist. Okay? This is so important. So what is the Doppler shift equation? Simply, the Doppler shift meaning the retaining signals. How much I'm going to send and how much I'm going to receive. And the frequency, if you hold the probe, there is a mark of the frequency on that probe. Okay? So that is the emitted frequency that goes into the heart. That frequency will go and retain. There is a retaining signal. Okay? A retaining frequency. That retaining frequency is called the Doppler shift. How much you get back depends on what? How much you get back depends on how much you send in the first place. And that's why the higher the frequency, the higher the retaining image quality. ودي معلومة لازم تكونوا عارفينها صح؟ The frequency is proportional to the image quality or to the resolution of the image. The higher the frequency, the higher the resolution of the image. With one caveat, the higher the frequency, the lesser the penetration. دي المشكلة اللي بتواجه الهاي frequency. إنه it's good في الimage quality, لكنه unfortunately depth بتاعه is low. It cannot penetrate so far. And that's why if you compare the pediatric probe with the adult probe, you'll find that the pediatric probe has higher frequency than the adult probe. And why is that? Because they are not concerned like us in adult echocardiography with the penetration, because they are dealing with the small chested children. Okay, so they are going to get the higher frequency and with a result of higher image quality, and the penetration, though it's low, but sufficient for children. While in adult, you are going to trade off the higher frequency with the penetration. Therefore, you are going to use lower frequency than the pediatric probe for the sake of achieving better penetration. This is one important fact you should know. Okay? Now, look at this equation. So the Doppler frequency is 2, the transmitted beam times V times cosine theta divided by C. V is the velocity of the blood. Cosine theta we are going to discuss. C is the speed of sound in the tissue. So what's the meaning of that? The meaning of that is what you get back depends on what you send and the velocity of the blood. Meaning, the higher the flow of the blood, the higher the Doppler frequency. Okay, C is constant because the speed of sound in the tissue is constant. Now, what is cosine theta? This is theta angle. The angle between the beam of the ultrasound and the flow of the blood. You see the one marked in yellow. Theta angle. You see that one, right? Now, what about this angle? You see it here. Again, the theta angle, which is the angle between the beam of the ultrasound and the flow of the blood. cosine theta means what in mathematical in Arabic? When we say cosine معناته بنقصد شنو؟
جيب الزاوية.
جيب التمام مش كده؟ ايوه جيب تمام الزاوية. طيب look at this one here. This is from the table of sine and cosine. The cosine 0 angle is 1. The cosine 90 is 0. So the highest cosine is 1. And the lowest cosine is 0 and in between. Okay? What's the meaning in that? What's the meaning of that in Doppler frequency, in Doppler shift equation? Meaning, if I need to achieve the highest value of cosine theta, which is 1, I have to have 0 angle. And if I have to achieve the lowest value of cosine theta, I have to be perpendicular. Because if I'm 0 angle, I have cosine theta of 0, which is 1. This is the highest value. But if I'm perpendicular at right angle with the flow of the blood, the cosine 90 is 0, and the retaining signals will be 0. And that's why 0 angle means what? 0 angle means parallel alignment. And that's why you hear a lot about parallel alignment, That meaning 0 theta angle. Okay? Like, if I cannot achieve, or how can I achieve this 0 angle between the beam and the jet? How can I do that? Any idea? Any idea? Yeah.
I need to optimize the image. For example, if I want to interrogate the aortic valve, I need to put in the middle and to make to be parallel to the flow.
Okay, good.
And this also for the other valves or the area that I want to interrogate.
So optimizing the image quality is one way, yeah. Second, it is also a matter of trial and error, because sometimes you don't know exactly when and how are you going to strike parallel alignment. Therefore, you have to interrogate many windows. Okay, that's why in the study of aortic stenosis, you can tell the patient to his right side and use the non-imaging probe, and you come from the right parasternal, you come from the suprasternal, you come from the apical window, multiple window scan. Okay, trying to find by chance, because you can't know for sure, so you have to do it in a matter of trial and error. The other thing is that you better be guided by color, because when you put color before you put your CW, the color can show you the direction of the flow, and you try to follow that direction by your CW interrogation line. Okay? And that's why, for example, sorry? Okay. And if we take the image on the left and reducing the sector, yeah, I agree with you. Reducing the sector, yeah, is always good. You have to just confine your sector to your zone of interrogation and try to dismiss the rest, because that will enhance the image quality. Okay, now if we take the image on the left and the image on the right, you see when they are scanning or they are interrogating the aortic flow, the one on the left is missing the parallel alignment, right? So what did they do? They did modified apical 5. This is one of the ways to overcome this problem, is to seek modified views. So you have to be technically literate. So you go down and you manage your probe in different ways as to achieve as much parallel alignment as possible. So when they did this one, they are more in parallel alignment with the jet. Okay, good. So failing to achieve parallel alignment will underestimate or overestimate the gradient. If I'm not at parallel alignment, am I going to underestimate the gradient or overestimate the gradient?
Underestimate the gradient.
Exactly, underestimate. And this underestimation goes from 0 to 90. 90, you are not only going to underestimate, you are probably going to get no signal whatsoever. Okay? But going from 0 to 90, there is a successive underestimation or gradual underestimation. Okay? And that's why they say probably up to 20 degrees, the underestimation is not so significant and might be acceptable, but after 20 degrees, the difference is big deal. Okay. Now, what is Bernoulli equation? Bernoulli equation is the second most important equation in echo. And I think you should all be familiar with because it's integrated into the calculation of gradients from velocities. So it basically converts velocity in gradient. Okay. Do you know this big one equation? The one on top? I wish you don't. Very good. Exactly. Tom Bernoulli is a physicist who came up with this equation long time ago, and it was actually pertinent to the physics of fluids. It has nothing to do with echo that time. It's basically the study of fluids and the dynamic of fluids within a closed system. Okay, but they have used it in echo because they assume that the heart is a closed system and blood is a fluid. Okay, but they cannot use this long formula. That's big deal. So this long formula encompasses the acceleration factor, convective factor, density factors. So they assume these are all negligible value in echo, and they end up with this modified formula, which is the pressure gradient equals 4 times the difference square between V2 and V1. What is V2 and what is V1? V2 is the distant or distal velocity. V1 is the proximal velocity. So if you are talking about two chamber or two orifices, the proximal orifice is V1. The distal orifice is V2. So in the aorta, for example, V2 is what is the aortic velocity. V1 is what the LVOT velocity. Okay? But they don't like it and they think it's a bit complex. So they say, you know what, V1 most likely it's lower than 1, so the value of which is negligible. So let's do it this way. Simplified. So they went from the modified to the simplified. So the simplified is 4V2 squared. So you see this simplified, it has come a long way through a process of omission and modification. And you have to know that because that entails, there are so many circumstances when this simplified equation does not stand true. Okay? One of which is عندي مثلا الproximal velocity is more than 1, then the value is considerable. So I have to get it in the equation and I have to use the modified instead of the simplified Bernoulli equation. Okay? This is one thing. الحاجة الثانية تذكروا قلت لكم في viscosity factor that has been eliminated from here. The viscosity factor. This viscosity factor is eliminated assuming that the blood viscosity is always fixed, but it's not always fixed. It can be polycythemia, it can be anemia. So the viscosity of the blood can change because of paraproteinemia, because of metastatic cancer, because of anemia, polycythemia. So, you know, that's a problem. Convective factor, which is thermal dissipation of the energy within a closed system, might also come into equation when we are dealing with serial stenosis. Like if you have an stenosis at the subaortic level, then at the aortic level. So I have two serial stenosis, Benoulli equation will not be accurate. So there are so many limitations of Benoulli that all comes from this aggressive modification and omission from the original formula. And you have to know that, the limitation of Benoulli equations, okay? Now, if you are using the simplified equation, it's simply the velocity, you check the velocity. Like here, for this signal, the velocity is 4 meters per second. So the gradient is 64. So it converts velocities into gradients. Okay? Good? So far, so good. You understand this, huh? Okay.
It is okay.
Yes, okay.
Now we come to the third equation, which is volume equation. How can I calculate the volume at any particular point or chamber of the heart? The volume is three-dimensional. When you say centimeter, cubic centimeter, which is ml, meaning you need to have 3 dimensions for calculation of the volume. So if I take this tube, for example, this tube, which is the aorta, if I want to calculate the volume of the blood in this tube, which is the aorta, I have to have the area of the circle and the distance. Okay, the area, this one. Okay, this and this one. These are the 3 dimensions. The area is 2 dimensions, and this is the third dimension. Okay, so I have to get an area and I have to get distance. Now, the area of a circle is what? You remember by نقطة ربيع, صح? That's the area of a circle is by نقطة ربيع. It's here. This is by نقطة ربيع.
Yes.
Okay? So this one over 4 equals 0.785 times diameter square. So they have made this one all easier for you. Instead of calculating pi over 4 diameter square, it is fixed 0.785 times diameter square. So this is the area. This is the area of this circle, okay? If I calculate it by the distance, and the distance in echo is the stroke distance, and the stroke distance is the TVI or VTI, اللي هي time velocity integral. Time velocity integral is distance, okay? So if I multiply this one by the TVI, I get the volume. So this is the equation of the volume. Okay? You get this one? Yes. Therefore, now if I have this LVOT, look at this LVOT. How can I calculate the stroke volume here at the LVOT? What do I need?
LVOT diameter.
Exactly, which is calculated this way, or which is measured this way. This one, okay? You see
yes.
it? So this is the diameter. What else do you need?
I will multiply it twice time, and then I will multiply it by 0.785.
Yes. So 0.785 multiplied by the diameter square. And then you multiply it by
TVI.
TVI. How you get the TVI?
Pulse wave.
With pulse wave in the LVOT.
Yes, exactly. And here you get the stroke volume at the LVOT. So how many signals or how many measurements you need to have for stroke volume calculation at any point? 2, diameter and TVI. Diameter and TVI. Diameter and TVI. Okay? And use this equation. 0.785 times diameter squared times TVI. You get the volume at any particular point. This volume can be at the mitral annulus, because the mitral annulus is circle. You can check the diameter. At the LVOT, at the aorta, at the RVOT, okay, wherever. Now, if I ask you a question, what is the most sensitive factor in this equation and liable to errors?
Diameter.
Diameter, exactly. A diameter is not always easy to measure. And the problem is a small minor mismeasurement can result in big changes in the equation because the diameter is squared. It is squared. So the error is magnified twice. Therefore, the Achilles heel of the volume equation is the diameter. That's why you have to be careful about this measurement in particular. Okay, good. Now, what is continuity equation? Number 3, the equation number 3, continuity equation. What is continuity? Here, continuity.
For aortic valve area calculation.
Yes, it is for basically used for the calculation of the aortic valve area. But it can also be used for the calculation of mitral valve area. Okay. Pulmonary valve, okay. And for regurgitation volume as well. Yes. Okay. The continuity equation again is based on a physical principle, which is the law of conservation of mass or energy. So within any closed system, the mass does not dissipate, is not lost. It will always be there. Okay. So what comes in must go out. The flow in the LVOT is equal to the aortic flow. Not only that, the flow in the tricuspid valve is equal to the flow at the pulmonary valve, is equal to the flow at the mitral annulus, is equal to the flow at the LVOT, is equal to the flow at the aorta. If there is no shunts and no regurgitation. Okay? So, if that's the case, let's take the LVOT with the aorta. If I measure the stroke volume at the LVOT is equal to the stroke volume at the aorta. And we know how to measure the LVOT stroke volume. 0.785 times the diameter times the TVI. That will be equal to what? Aortic area times the TVI of the aortic flow. Agree?
Yes.
Yes.
And if I don't know the aortic valve area, now I can know. Because I have the stroke volume at the LVOT and I have the TVI of the aorta. So it is just as simple as this one. If we take it this way, sorry. So it is 0.785, this one, times diameter square of the LVOT times the TVI of the LVOT. That will be equal to aortic area, which I don't know, times the TVI of the aortic flow, which I can know. So in this case, I can work out the aortic valve area. Okay? And this is how they measure aortic valve area by continuity equation. Good? Good. Okay. So now you know the continuity equation. This is number 3. Before we dive into the 4th equation, I wish you just grasp this concept of velocity ratio. Velocity ratio is the ratio of the proximal velocity over distal velocity, whether you are using peak velocity or TVI, but it's better to use TVI than peak velocities. Yani, it is the velocity in the LVOT divided by the velocity in the aortic valve. What is the importance of this velocity ratio, which is also called dimensionless index? The importance is, anybody knows?
Depends on the diameter of it.
Sorry?
Not depends.
شوية, your sound is distant.
It does not depend on the diameter. No need to calculate the diameter of
Exactly. Yes. So you are gonna get away with the diameter. What is severe aortic stenosis based on the velocity ratio? What defines severe AS based on velocity ratio?
25%.
Yes, 0.25. Lower equals to or lower than 0.25. What's the meaning of this? The meaning of this is that the aortic valve is significantly or severely stenotic if its velocity is 4 times the velocity of the LVOT. That's the definition of severe aortic stenosis. Severe aortic stenosis is defined as a velocity of the aortic valve flow 4 times that of the LVOT. Therefore, when you divide LVOT by aortic velocity, you get 0.24. 0.24. Okay? So that's why 0.24, where 0.24 comes from. Okay? This equation lets you get away with the diameter calculation, and it also have another important value, which is what? It lets you get away with flow, with flow problems. ايوه، ما نحن الدكتوره قالت it lets you get away with the diameter. ثاني it lets you get away with the flow. لانه الفلو في الاورتيك فالف is a big deal. بمعنى إذا مثلا patient has severe aortic stenosis لكن low flow because of low ejection fraction, I get stuck. I will not elicit a mean of more than 40. If I have severe aortic regurgitation, the mean gradient across the aortic valve might be high, though I don't have significant aortic stenosis. So this flow problem will be adjusted if I use velocity ratio, because if I have a problem in the flow, it will be equally happening in the LVOT and the aorta, and the velocity ratio will remain fixed. Okay? Okay? Okay, Juana?
Yes.
اوكي انا بس مهتم جدا بانه تفهموا الدايمنشنلess index لانه it's an important measurement وزي ما قلنا it lets you get away with diameter and flow. Good. Now CW and PW واتوقع انه مجتبى has يعني spoken about it in depth ولكن no harm in just mentioning it briefly that the difference between CW and PW relates to the physics of each. In the CW, you have two crystals. One is always sending, one is always receiving. While in PW, you have one crystal that sends, waits, and receives. Okay? Right. Let me just mute some. Okay. So you get this one because this is important. So just kind of like commonsensically, if you have two crystals that keep sending and receiving, chasing velocities, what do? They will capture high velocities, like they will be confused about the location of these velocities. And this is exactly the problem of CW. CW misses the location, lakin it captures high velocities. Now PW is what? PW is one crystal that sends, then waits, then listens. So it's not fast, So it can miss high velocities, lakin because it waits and listens, it precisely locates from where the velocity comes. Okay? So the PW misses high velocities, lakin precisely locate the origin of the velocity. يبقى بس let me mute. Okay. So in other words, we are talking about velocity range and sample range. When we talk about velocity range, يبقى CW has a wide velocity range ولا narrow velocity range?
Wide velocity range.
Wide. And PW has limited velocity range. Now sample range, how much of an area?
Narrow velocity range.
Narrow velocity, narrow sample range in what?
Detecting
Narrow,
high velocity.
a sample range will be low or narrow in PW, صح؟ لأنه PW, it gets you from where this high velocity comes. لكن ال PW has a problem with the sample range. Therefore, if you get high velocity, you don't know from where it comes. It can be coming from anywhere along the entire path of interrogation. Okay? يبقى بمعنى آخر. If you are chasing high velocities, CW is the way to go. If you have no problem with velocity, it's better to use PW because PW tells you exactly where this velocity comes from. Therefore, mitral valve and tricuspid valve inflow, PW or CW? Mitral valve and tricuspid valve.
PW.
PW. Aortic valve and pulmonary valve.
CW.
CW لأنه high velocity. VSD.
CW.
CW لأنه high velocity. LVOT.
Pulse.
PW. TR velocity.
CW.
BW.
TR velocity.
CW.
CW, yes. LA appendage velocity. Pulmonary vein velocity. Pulmonary vein velocity.
PW.
PW. Hepatic venous velocities.
PW.
PW. Exactly. So now you know. Good. What is the problem of using PW in high velocity? We said that if you use PW, because لأنه PW عندها, the limitation of PW is the high velocities. Okay? فبتحصل حاجة اسمها aliasing. And aliasing is a confusion of the signal. So it gets signal wrap around this one. You see now هنا مثلا the UCW and the entire signal is shown above the baseline, and you can know the start and the end of the signal. But if you use PW for the same signal, which is high velocity, beyond the capacity of the PW to capture, it will get aliasing. So the signal will be cut into two, one below, one above. So you get lost. You don't know where it starts, where it ends. Okay. And here it is. يعني تشوفوا هنا مثلا where is the aliasing? الaliasing هنا حصل للmitral regurgitation. The signal of mitral regurgitation is this one. You see it? It's this one. Okay. This signal, one here and one down. It gets aliasing because the PW can capture low velocities, but gets mixed up with high velocities in an aliasing process. Okay. Good. Now you know. Very well. Now, if I have to use the PW, you will always get this one. Look at this one here. This line with an equal sign. What is this equal sign?
This is the area of measurement.
Exactly.
Exactly.
This is the sample volume. بمعنى, if you put PW this way, you have to locate your sample volume to where you want to get the velocity from. So if you put it in the LVOT like this one, you get this one, LVOT velocity, okay? If you put it here at the mitral inflow, like this, just below the leaflet, you get the mitral inflow this way, okay? Therefore, you have to know exactly where to position your sample volume when you are using PW. And this is sensitive, by the way, لأنه if you move the sample volume up or below the desired location, the velocities will change and you will end up obtaining erroneous velocities instead. So you have to be trained technically as to where to put your PW sample volume when you are interrogating different locations. في LVOT, they know where to put it. في mitral inflow, you know where to put it. في hepatic venous Doppler, you know where to put it. في pulmonary vein, you know where to put it. Okay? Good. Now, what is the max and mean pressure gradient? And max pressure gradient from here, let's take this one, aortic valve. Where is the max? How you get the max pressure gradient?
Almost around 4
At the
meters.
tip of the envelope.
4, exactly. So the peak velocity. So you are going to choose the peak velocity. And you convert it into pressure by 4V square, right? Done. How I get the mean? How I get the mean?
I will trace the envelope.
Exactly.
By tracing.
By tracing. So by tracing of the velocity drop, you trace the velocity drop. طيب, how the machine is gonna calculate the mean pressure gradient?
Divide the velocity among the time.
Over time, velocity over time. Mhm.
All
هو
the,
أها
the pressure, and then it will take the mean of it.
أيوة the mean.
Because every line here demonstrates a different
exactly.
pressure.
You've got, yes, exactly. You remember when you are tracing the velocity, you will get some dots, right? Dots.
Yes.
Dots. What are these dots? These are sample velocities selected by the software. So they select, let's say, 20, 30 velocities across the spectrum, this envelope. Okay, each velocity is converted into a pressure gradient. Each one, and then the pressure is summed up and divided by these number of velocities. So if they have samples 10 velocities, they convert them into pressure, they sum up these pressure and they divide it by 10, they get the mean. Okay, so the max pressure gradient is relying on a single peak velocity. The mean is an average of multiple velocities across the envelope of the spectral signal. Okay? You get this one?
Yes.
Okay. Good. So this is the mean pressure gradient. Type one problem with the peak and mean are both flow dependent. Yani, if you are studying the gradient for AS or MS, you have to remember that they are exquisitely okay, that these gradients are exquisitely sensitive to flow. يعني إذا في high flow ولا low flow, the pressure gradient will change. Well, that's why when we talk about aortic stenosis, we always consider the flow. If we have low flow, high flow, normal flow, حتى الMS مثلا إذا عندك tachycardia changing the flow or bradycardia changing the flow, the gradient will change. The loading condition, the amount of fluid status, كلها بتغير الفلو and therefore will change the gradient. So the gradient changes a lot with the flow. And that's why when the very initial slide, we showed إنه the anatomical data is more important لأن anatomical data is more fixed than the hemodynamic data. Hemodynamic data changes from day to day, time to time, management to management. يعني patient عنده MS مثلا أو عنده rheumatic mitral valve by area مثلا area is lower than 1, so it's severe mitral stenosis. I measured the gradient today and it is 15 mean. بعد patient مثلا we control his heart rate, the pressure is 9. Okay? مثلا بعد patient he exercise or today he is a bit volume overload for some reason, his gradient is 12. So the range of the pressure gradient occupies wide area depending on the loading condition, on the heart rate, and the amount of flow. Okay, so you have to remember, your hemodynamic data might change depending on the change of the hemodynamic statuses. Okay. Now you know how to calculate the pulmonary artery systolic pressure, and this is the last equation, the pulmonary artery systolic pressure. How
Yes.
are you going to calculate it?
I will take the
QR
peak.
velocity, then adding the IVC later or the right atrial pressure to it.
Exactly, exactly. So you calculate the peak of TR, and you know where this equation comes from, okay? And when you calculate the TR peak velocity, the pressure gradient is the RV systolic pressure, right? You agree?
Yes.
Okay. RV systolic pressure is equal here. It's based on an assumption that the RV systolic pressure is equal to the pulmonary artery systolic pressure. Right or wrong?
Yes.
Yes.
It's right. Unless I have
TR.
Pulmonary
no
stenosis.
pulmonary stenosis.
Exactly.
Exactly. The RV systolic pressure is equal to the pulmonary artery systolic pressure unless I have PS. The LV systolic pressure is equal to the systolic blood pressure unless I have AS. Okay? So the RV systolic pressure, you calculate the RV systolic pressure from the TR signal by this pressure gradient added on the right atrial pressure. And the right atrial pressure is derived from the IVC. Crudely, it's rough estimation. وبالمناسبة يعني واحد من أخطاء البلمونري artery systolic pressure هو الريلاينس على الاي في سي، لأنه يعني it's so crude assessment إنه والله diameter collapsible not collapsible، وفي ناس مثلا young athlete تلاقي الاي في سي حقهم 2.5 وتجمع 20 ولا 15 وهم ما عندهم قدر ده وهكذا. اوكي، فالاي في سي is an Achilles heel of this one. The other thing is that the TR velocity, our TR signal itself might not always be easily obtained. Okay, ما دائما بتقدر تحصل عليها صح؟ مش كده؟ ما دائما. يعني مرات you have to search so thoroughly through different windows عشان تحصل عليها. فبالتالي دي واحدة من المشاكل بتاعت الpulmonary artery systolic pressure. اوكي؟ الحاجة الثالثة والمهمة، if you have severe TR, are you going to underestimate or overestimate the pulmonary artery systolic pressure?
It will underestimate.
Why?
Because the velocity will decrease so much.
Exactly. Because the severe TR tends to decrease the velocity. And why the velocity decrease with severe TR? For two reasons. واحد إنه لما يكون عندك severe TR, it tends to be laminar with no much of velocity. الحاجة الثانية severe TR will weaken the RV. When it weakens the RV, السيستوليك pressure حقته بتقل. A severe TR will elevate the RA pressure, and the RA pressure opposes the TR. So the TR velocity will diminish. So severe TR ممكن الايفالويشن بتاع البلمونري artery systolic pressure ما يكون accurate. Okay. So I think that's it. These are the four equations of Doppler اللي هي اتفقنا على انه نشتغلها this tonight، اللي هم the Doppler shift equation, the flow volume equation, continuity Bernoulli. These are the four main equations you have to grasp and know about. And if you have any questions, I'm ready.